Hello, I'm Dr. Sabi, board certified Permanente OB-GYN practicing in suburban Maryland. I am thrilled today to be joined by two of my incredible colleagues, Dr. Kathari and Dr. Carolyn Gorman. We're so excited to be talking to you today about a subject that is very near and dear to my heart. Welcome, Dr. Kathari. Would you like to introduce yourself? And you're on mute.
Thank you, Dr. Sabi, for getting us to this amazing discussion, which is so important to our patients. So I'm a board certified OB-GYN. I'm in Burke, Virginia, and I'm also a NAM certified menopause practitioner and a fellow of the International Society of Women's Sexual Health. So two topics that form a big part of my practice. So thank you so much for inviting us.
Sure, it's great to have you. And Dr. Gorman.
Hi, yeah, I'm also a board certified OB-GYN. I practice out of the Capitol Hill location. And like Dr. Kathari, I'm involved with the ISHWISH, or International Society for the Study of Women's Sexual Health. And I also had a certificate program through University of Michigan for women's general sexual health and sexual health dysfunctions program. So those do occupy a lot of my time with my patients, which is great.
Thank you both. And it's interesting because as a practicing general OB-GYN, this topic is very near and dear to my heart. And as I get older, personally, very important for me. And still, there's so much new information out there. There's constantly new treatments and options. And so I personally have referred my patients to you, and you have been very gracious in answering my questions. So I really, really appreciate your expertise. For our discussion today, I think it would be good to start off with just a general idea of what is menopause. Everyone has symptoms in a different way, and everyone goes into menopause in a different mechanism. And so just talking about that, also talking about some of the lifestyle changes. What are some of the natural things that we can do to help ourselves transition into menopause? And then there are some hormonal treatments, non-hormonal treatments. So just understanding what the options are, what the risks and benefits of those are. And then I think, very important for a lot of women and couples is just the sexual dysfunction, and how do we address that, and what are some of the things that we could do? So maybe Dr. Kathari, we'll start with you, and just I think many people will kind of know what menopause is, but can you tell us a little bit more about menopause and how do women go into menopause?
So menopause, the technical definition is really when someone does not have a period for a year. So that is, your final menstrual period. But it's really important for a patient to understand that some of the changes start way earlier than that final period. So, it starts, from 48 to 52. Most times the most severe symptoms are usually, a couple of years before menopause and a couple of years after. So a lot of times people would say, oh my God, I've hit my 40s or 45, I feel my body's like going through a roller coaster. I feel like I'm a teenager. Someone said, they mentioned, oh, I feel like I suddenly like winters, I can stand in like the snow, and that's the best thing. So kind of, that time frame from like 48, 50, to 50 to sometimes even 55. So that's, the perimenopausal phase is really, really important to kind of talk to our physicians and say, what is going on with my body? Please educate me.
Mm-hmm. And then Dr. Gorman, so besides women who are getting older and, in that over 45, 50, what are some other ways that women can go into menopause?
Well, certainly that's the, natural way of just, your ovaries aren't working as well in producing estrogen. But there are some women that for, different medical reasons need to have surgery. And sometimes their ovaries are removed during surgery. And that can be really an abrupt change that can just wreak havoc on their lives. And that, for some women, it can be, as early as in their 30s, if that needs to happen. So, ideally, it's just kind of a natural slowdown of your periods. But that doesn't always happen. And it's also tough to realize that, women who've had a hysterectomy, they're not going to know when their period would be stopping if they still had a uterus. And, just having your uterus removed doesn't put you into menopause. And then we just have to go based on symptoms. So if you're, when are your hot flashes starting and things like that. So it's a little bit trickier to know, like, are you in menopause after hysterectomy? But it's also just, it's really important on, how are you feeling? That's really the better question.
So we'll stay with you, Dr. Gorman. I think, many people experience menopause in different ways. What are some of those common signs and symptoms that people will have?
Well, so Dr. Kathari already started talking about kind of the changes in your periods. Can start, anytime in their 40s. So often that's a lightening of your period, maybe a irregularity where they're becoming less frequent. Sometimes it can actually happen where you might not have a period for a while, and then it can be really heavy or prolonged. That still doesn't necessarily mean something bad is going on, but certainly if you have really heavy bleeding or really frequent bleeding or prolonged bleeding, you need to talk to your OB-GYN about that. Aside from bleeding symptoms, a lot of women will start having those hot flashes even before their period stops. Sometimes they'll notice that they're having some vaginal dryness, maybe during sex only, maybe even outside of sex. Their mood can be changing, and that might be because they're having difficulty sleeping at night with hot flashes. But it's just, we know that our moods can go up and down more so when we get into menopause, and depression becomes more common. So these are all things to be aware of, and not to hesitate to talk to their OB-GYN.
Thank you for that. And Dr. Kathari, any other signs or symptoms that you have heard from your patients that someone may be starting to enter hormonal changes leading to menopause?
Yeah, so like Dr. Gorman mentioned, one of the big changes is cycle changes. So they suddenly say, oh, my cycles are becoming shorter, heavier, hot flashes for sure. So vasomotor symptoms. They would describe it as suddenly I'm feeling hot or cold. Night sweats is a very common thing. Lack of sleep or insomnia. I'm not sleeping. I'm waking up at 2 o'clock in the morning and I don't know why. I've always been a good sleeper. Mood changes, so some of the NAM studies have shown that people who have some underlying mood disorder, sometimes it can worsen, especially with the fatigue and the lack of sleep, right? So that's a big one. Weight gain is a huge one. It's a very
I'm
big
glad you
one.
mentioned that. I was going to ask
Yeah.
about that because I hear that all the time.
All the time, like suddenly, like they're like, I'm doing the same diet, same
Yes.
exercise, I'm super active, I'm just gaining weight. And it's very frustrating for our patients because they're like, I'm doing all the right stuff, what happened to me, right? So that's weight gain is a big one. Skin changes, acne. So those are some of the very big ones that we see. Like sometimes they say, I feel like I'm hitting puberty again, with my face, skin
Mhm.
changing. I have a teenager at home, but I feel like I'm also a teenager. So it's those are generally the kind of symptoms that, but vasomotor symptoms and weight gain is the biggest one.
As women are starting to have some of these symptoms, and I'll start with you, Dr. Gorman, what are some just really easy things that they can start to do, mainly lifestyle changes, to help combat some of the signs and symptoms of menopause?
Yeah, a lot of things they might just kind of do just naturally because of their symptoms. So, they start having fans by their bedside, dressing in layers that they can easily come off, maybe more blankets, but, they can pull off one blanket and they still have a couple more. Things like that they can definitely do. And some women will find that there will be, almost triggers for hot flashes. So they might notice that, alcohol intake or caffeine, certain activities will kind of trigger a hot flash. Sometimes just, kind of like your emotional ups and downs will trigger a hot flash. So recognizing those triggers and obviously trying to avoid them, or just, I'm going to have my glass of wine and I'm going to get a hot flash, and
Yep.
and that's okay. So, things like that. And then, those are the more natural things that they can do. And then, in terms of sleep, it's really important to practice good, what I call sleep hygiene. So things like that they've probably heard, but a lot of us don't always follow, myself included, not always. But turning off the screens like an hour ahead of time, really just being in your bed for maybe sexual activity and sleep. But try not to get used to doing a lot in your bed, which is hard, especially during the pandemic. We probably all are at home more, and certainly some people might be sitting up in bed doing some work, but really trying to make the bedroom and the sleep area just really for sexual activity and sleep, so that your body kind of knows, like, I'm going into this space and this is what I'm meant to do, and fall asleep.
That's really helpful. And Dr. Kathari, so you mentioned the weight gain and the changes in metabolism that come as a result of changing hormones. And, I commonly tell myself and I, tell my patients, this is not your fault. You're not doing anything wrong. But what are some of the things that women can do to help with the weight gain? And, it also helps, I think, with all the other symptoms of menopause as well.
Right. So one of the big things I really tell them is, diet. So some of the diets have shown to have a plant-based diet, a Mediterranean diet. These are small studies, but they have shown to have some effects on weight. And we have fantastic nutrition people in Kaiser Permanente. So, I really tell people, talk to them, see how they can modify your diet. Make little changes in your diet. Try to have a diet that's more, non-processed. But also I tell them to be kind to themselves. I mean, it's the pandemic. You are at home. You have kids. It's easy to snack a little bit. So people take that very seriously. The other thing is exercise. Try to incorporate at least 20 minutes of exercise every day, walking, running, jogging, swimming, whatever they like. Supplements don't really work as much. I mean, unless they are beyond a certain BMI, I tell them, talk to your primary care doctor, see if you can, if you can be in any one of the programs. We have lifestyle programs, nutrition programs. So we have a lot of great resources. And I really tell them, encourage to use them. But plant-based diet small studies have definitely shown some benefits.
That's great. And Dr. Gorman, so one of the things that is not commonly discussed, but I think it's really important for people who are getting older and women who are going through menopause is as the hormones change, the estrogen levels decrease, the bone density goes down, and the risk of breaking bones goes up. What are some of the things that can be done to help, exercise being one of them, to help decrease the risk of osteoporosis or osteopenia, which is thinning of the bones?
Sure. So, we've got things that we can't change, right? We can't change our genetics. We can't change our age. There's no going backwards. But the things we can change are definitely our diet, making sure that we're getting a healthy, balanced, calcium, rich diet. Calcium's important, but even more important, even before we get to menopause, to make sure that we're, hitting our peak bone density as high as we can. But also then, the exercise, particularly the strength-based exercise. So that doesn't mean you need to go out and, purchase a lot of weights and just start doing a lot of weight training, but it could be, as simple as going for a walk, but, carrying something while you're doing it, or putting it on some ankle weights or wrist weights. The more weight-based exercises you can, that helps promote bone growth. So those are two things there: the calcium and the strength-based. And then, again, minimizing the alcohol as well is important too. Not necessarily taking it out altogether, but keeping that in moderation.
That's really helpful. And I think one of the things, and I hope that people who are watching this, if you have any questions, please type them into the chat because we would love to hear from you as well. I can ask questions all day of my amazing colleagues. Thank you guys for your time. I think one of the really important things for someone who is watching this, and they're either personally going through menopause, they have a loved one going through menopause, is understanding and taking stock of what the symptoms are that they're having. And I'll start with you, Dr. Kathari, with the next question. But I think once we have an understanding as physicians what the main symptoms are, right? So there's so many different symptoms that can happen. But once we know what the actual symptoms are and how much they're impacting the quality of life, we then can talk about treatments. And so, Dr. Kathari, can you talk about some non-hormonal treatments that are out there, depending on the symptoms that people present with?
Definitely. So like you said, the most important thing for people is to really, you know, discuss their symptoms, like what is affecting their quality of life, how much is it affecting, if I put it into buckets, if it's very mild, like Caroline said, go into diet and nutrition and, but after 3 months, your symptoms are getting worse, then I would usually start with, I would say, look, we have the antidepressants, like the SSRIs, which have a great impact on hot flashes, like fluoxetine, Prozac or paroxetine. They have good studies to show that they do help with hot flashes. So for example, someone who has underlying mood disorders and has bad hot flashes and does not want to go on hormone replacement therapy for now, it's a great option. Gabapentin is another one. So I would say try that for 3 to 6 months, along with your lifestyle and diet, and see if it makes a difference. If it doesn't make a difference, then, email me, I'll follow up and let's talk about hormonal options.
That's right. That's right.
Yeah.
So, Dr. Gorman, can you maybe talk a little bit about, you know, uh, what are some of the contraindications to hormone therapy? Who is a candidate for hormone therapy, and why do we worry about it? Because I remember, I trained over 25 years ago, and when I first started training, almost all women going through menopause were put on hormone replacement therapy, and the studies have shown that that may not be the right thing. So, can you talk to us a little bit about hormone replacement therapy pros, cons, what you typically tell your patients?
Sure. I do remember that. I think during my training, it was like the fountain of youth. Everyone was on estrogen, like this is going to make us live forever. And to be honest, I think some of the initial studies that came out in the early 2000s had some scary results that have put, kind of a bad spin on estrogen, but undeservedly. So I think it's really important that we talk about it. First off, I do want to make a big difference between when we talk about hormone replacement therapy. In my mind, there's a huge difference with estrogen, vaginal estrogen, and either oral or transdermal hormone replacement therapy. I think it's really important. When I say hormone replacement therapy, and I'm talking about the pros and cons, I'm really talking about those medications that give you estrogen that's really systemic, okay, that's going all throughout your body. When we talk about vaginal estrogen, that's really localized to the vagina. And so it doesn't necessarily have the same risks and benefits that we're going to talk about. So it's not going to get rid of hot flashes. If I put estrogen in your vagina, you're still going to have hot flashes. Your vaginal dryness will be solved, which will be great. So I think that's a really important difference. For hormone replacement therapy, to answer your question, I think, one thing we found, and we knew this for a long time, but estrogen does have some risks of cardiovascular events, especially clots, DVTs in your deep vein thrombosis in your legs, or clots in your lungs, which are called pulmonary emboli. These are very dangerous. It can be life-threatening. It's not a great percentage, but it's real. And those patients that have underlying health conditions that put them at risk for cardiovascular events may not be great candidates for estrogen, hormone replacement estrogen. Women that have a history of breast cancer may also not be great candidates for systemic estrogen. Now, it's complicated. So I really, I think a lot of women just have written off hormone replacement therapy altogether. And I think that's too bad, because there are women that are great candidates. And, I would tell everybody your OBGYN is the one to help kind of figure out which camp you fall into. So if you're in general healthy, and you don't have high blood pressure, high cholesterol, or even if you do, but it's controlled, you could be a really good candidate. Your age is really important too. Some of the studies, that we looked back on and reflected on after the initial results were out, found that the timing on when we start hormone replacement therapy is very important. So if you're between the age of 50 to 59, when, a lot of these symptoms are arising, you can still be a really good candidate for estrogen. And in fact, we've seen that it can decrease some of these cardiovascular events. It's really kind of when you get to 60 and above, and we're newly starting you out on on hormone replacement therapy, that we find that there's a significant increase in cardiovascular events and clots and heart attacks and things like that. So, age is a huge important factor. And, that's why we're here, to kind of figure out this complicated medication, and help find women that are good candidates for it.
I think if we think about the growing population, half of the population being women and going into menopause, and Dr. Kathari, I'll address this question to you. I think, there's a lot of lucrative businesses out there, lots of very expensive testing that is done, treatments that are done. I think, the world has marketed bioidentical hormones and labeled this to make women feel like they're getting a very special treatment. Can you talk about that? What does that mean? And do people really need that? Or what do we do about that?
Yeah, so it's very common. We see a lot of people with a lot of testing that comes from outside, but really the guidelines are that it really depends upon your symptoms. So what your symptoms fall into, because someone who has the hormone levels like the FSH, which talks about the ovarian function, can be very high, but they may not have bad symptoms. So, so the testing that is done outside is it really depends upon the patient's, the most important thing what I do is I look at the cardiovascular risk factors if I'm thinking about starting hormones. And I say, what is your lipid panel? What is your blood pressure? Before, calculate the ASCVD, which is that risk factor, to really see if they are candidates, right? So the blood testing is more than that. I really look at quality of life issues for the patient and their underlying health conditions. The second thing is very important is the bioidentical hormone. So it's really people, bioidentical hormones, all it means is hormones that are still produced synthetically, but are closest to our natural hormones. And we have some fantastic FDA approved options that are bioidentical in our pharmacy. They are titrated for safety. They have good, like the Climera patch, the estrase patch, which we have. It's a fantastic option. So people do not need to go to the compounded bioidentical hormones, because that really, they are not tested for safety. We don't know where they're made. Like with the vaccine thing in Boston, we really don't know. So I'll just give you a simple example. I had a patient who had a compounded pellet put outside somewhere. And then she came in with tingling and pain down her legs. And I had no idea of knowing where the pellet was put, what was in the pellet. It was a compounded thing. So I really tell people, please, if you have any questions on bioidentical hormones, please talk to us. We have good FDA approved options. We have patches. Don't go outside and spend a ton of money on things that are not approved, not safe.
And I think the key to that in the conversation that I typically have with my patients is the whole goal of the concept of bioidentical hormone treatment is personalizing whatever treatment to the symptoms that are bothering the patient the most. And so, for those of you that are listening and you're thinking about talking to your doctor about any type of treatment, it's really important to take stock of what is it that is bothering you the most. And if you had to pick one or two things out of the list of five that you want to improve, what is most important to you? And that way we can work with you, whether it's non hormonal medication or if it's hormones, whether it's a pill, a patch, a cream, we can tailor that personal treatment to the symptoms that you're having. I want to thank people who are listening to this call. We're getting a lot of great questions, many questions, and I think a really important topic, and it'll go very well with our next area of focus is vaginal dryness and sexual health. I'll start with you, Dr. Gorman, talking a little bit about vaginal dryness. What are some of the things that can be done? And one of the questions that came up is, and I hadn't heard of this, so I'm going to learn with everyone else, the Mona Lisa vaginal dryness technique or treatment.
Yep. So I'm going to start with just vaginal dryness in general. A very, very, very common and normal change in our body. But because it's normal, we don't have to put up with it. I mean, that can be very disruptive, especially during sex. Sometimes even outside of sex, it gets so dry that women will feel that. So, I mentioned vaginal estrogen before. There is rarely a patient that can't take vaginal estrogen. So I think that is really, really important to stress. And I have to talk to my patients. I've learned through mistake that I have to explain that, the risks we talked about before that are associated with systemic hormone replacement therapy are not risks for vaginal estrogen. And the tough part is FDA still mandates that all those risks be listed in the package insert for vaginal estrogen. So I've had, in the beginning, I would prescribe it and then the patients would get home and read the package insert and be like, are you kidding me? I'm not taking this. Look at all these risks. And so then, I learned, so I have to explain that. So they have to trust us that, vaginal estrogen is very, very safe. And that's, something really easy that we can do that can make a huge difference. It can take away the pain, the dryness, return some sensation to the vagina and the vulva. So it's great. That I think of as a moisturizer to kind of like we could put on like a face lotion every night. This is a vaginal moisturizer. And, in addition to that, we can also recommend lubricants. And there are, water-based lubricants, silicone-based lubricants, and oil-based lubricants. And I will say I don't recommend oil-based lubricants. And of the water-based and silicone-based, I actually really recommend using silicone-based lubricants. They can be a little bit messier and to clean up, but if you put, some water-based lubricants in your fingers and rub them together, and then some silicone, the silicone lubricant is a lot silkier and it lasts a lot longer. It doesn't have to be wet or anything like that. There are some, if you're using any kind of toys that are made out of silicone, that's the time that you'd always want to use water-based. But other than that, I always recommend silicone-based. So for sex, the vaginal estrogen, the silicone lubricators, those are the first two things that I would recommend. Now, the Mona Lisa touch, I'm going to briefly talk about that. That is a method of getting some more elasticity back into the vagina. So a lot of times it's used on menopausal women, or perhaps women that have had chemotherapy for breast cancer that have really dried out their vagina, maybe tightened it up a lot so that there's pain with sex. And the Mona Lisa touch is, I would say still kind of in the experimental phase, but there is a lot of good research. It gives like micro abrasions to the vagina. It's not painful, but what that does is it stimulates kind of a regeneration of some of the tissue. So it is, I think for the right people, it is something that is going to be recommended. I don't know that we have all the information we need yet to be able to use it, but I am not discounting the Mona Lisa touch for the right candidate. And there's a lot that can be done just with the vaginal estrogen that we already have. So I think the Mona Lisa touch is really in my category of like to be determined, like where are we going to use this the most and get our best bang for our buck there.
Thank you for that. And I learn something new from you every day, so I appreciate that. Dr. Kathari, can we talk a little bit about what happens after menopause? Why is that vaginal dryness important? What happens to the elasticity or the stretchability of the vagina? And Dr. Gorman touched on this a little bit, but frequency of intercourse, using toys, using lubricants. Why is that important, and what is the goal? What are we trying to accomplish with those treatments?
So again, a lot of it just depends upon what the patient is looking for, right? So it's important to kind of walk backwards and say, what is your goal? How many times are you sexually active? What is hurting? Is it hurting on penetration? Is it deep insertion? So those are little things that are very important to figure out what's going on. And what happens with the vagina is really like with our body, the estrogen is aging, So imagine if it's the elastic, and all the elasticity starts going down, the rugosity starts going down. So it's like a dry skin, right? When something rubs against really dry skin, it is going to hurt. And so the vagina, what we do with the vaginal estrogen, like Carolyn said, is really putting back some of that estrogen back into that vagina to get that elasticity, to get that rugosity back. And it really, really works wonders. It is such a safe option. Usually what I do is I tell them use the estrase cream 2 to 3 times a week. And along with that, use the lubricants, but there are also some moisturizers on the market, which are, again, the hyaluronic base, now it's the big thing. Everything is hyaluronic based, like face everywhere. So again, they have some, and I've had some patients with some good responses to like Replens or one of the moisturizers. So if they have a kind of a regimen that they follow with the estrase cream and the moisturizer and the lubricant, I mean, their pain is pretty much gone. Dilators is another big one. So for someone who has got radiation or has surgery, the vagina really gets tight. And so, dilators is a great option. I tell them, buy one of them, not the very expensive ones from Amazon or somewhere. Watch Netflix, sit in a bathtub, use the dilators. It's under your control, and when you feel completely comfortable with using those dilators, then you can maybe go on to, having more sex. Because if they're going to associate, it's a mind-body connection. If they're going to associate something with pain, they're not going to want to do it, right? So first, it's important to address the issues and have them say, take it slowly, let your body heal. And so I think a combination of all these things really, dilators are another great option. Vibrators, but more dilators, if they have a lot of pain.
I think the other question that commonly comes up is for a woman who is starting to have that vaginal dryness and having pain with intercourse, the natural instinct is not to have intercourse. And then the spacing, between times that she's sexually active increases, and then the psychological component with that, and then even sometimes tearing or just severe pain after intercourse. Dr. Gorman, what are some of the things that you tell women who come in and they're saying, I'm having a lot of pain, we're not having intercourse frequently, but it is important to my relationship?
Yeah, I actually had a couple patients just this morning with very those exact concerns. So, the pain can be coming from a couple different components. So we've been talking about a lot about vaginal estrogen, and that's really addressing kind of the tissue, the exterior tissue, the vaginal walls, and at the vestibule or the opening to the vagina. But if we've neglected that, or for various reasons, a lot of times the muscles underneath can be really, really tense, and that can contribute to the pain. So I try to isolate, is it a tissue pain? Is it a muscle pain? Because sometimes not the estrogen is going to be really important, but sometimes we actually have to get women into physical therapy. And we have there's a group of women here at Kaiser, but just in general, physical therapists that are called pelvic floor physical therapists, and they do wonders. They address not only issues around painful sex, but a lot of other menopausal issues like prolapse or incontinence, urine leakage. So they are a great resource that we have. And they can actually, if women need dilator therapy, they often will help women kind of walk through that with them and guide them through that. So like you said, a lot of women will reduce the frequency of sex when they're having pain. And when we aren't having sex, the tough part is the vagina is kind of a use it or lose it organ. So, that if it's not used with penetration on a regular basis, the width of the vagina can narrow, and it can also shorten. The length can shorten. So having something inserted, whether it's through penetrative sex or whether it's through a vibrator, dildo, or something to keep that that vaginal opening there, is really important. Now, when there is a lot of pain, that's tough because we don't want to necessarily cause more pain and have those muscles tighten up even more. So sometimes just using kind of their thumb or a finger to kind of massage the opening and using the estrogen cream until that pain is improved is a good idea. And this is, something that they can work on with the physical therapist closely to know when is it okay to kind of resume sex again, so that we're not, kind of putting pain and pain and pain over and over again and causing those muscles around the vagina to tighten up.
This is definitely a hot topic because we're getting a ton of questions through the chat. And I know that we're not going to have a chance to get through all of them, but I'm going to try to see if we can address as many of them as we can. Dr. Kathari, can you talk a little bit? So we've talked, and I think there's a lot of interest in hormones. What are the age restrictions? What are the recommendations for ongoing use of hormones, whether it's oral or patch?
So it's really, Sabi, so one of the things is that we try to start the hormones as close to menopause and before 60. But if someone is on the hormones, the new guidelines are not to stop them, but rather look at the risk benefit analysis. So, so it used to be, oh, now the person is 65, let's stop. That's not the guidelines any longer. It's more looking at the cardiovascular risks. So sometimes I have patients who are 72 and they're like, they will not stop their hormones. They're like, it's completely devastating my life. And if I find they're healthy, the risk factors are low, I talk to them. So it's a continuous communication between the doctor and their patients who say, what is happening? And I usually will only give it to them for a year. And I'll say, you need to come talk to me in a year, because in a year, a lot of things change, right? They may have a history of new strokes or new something. So that constant communication, but I don't just, it's not a stop. It's basically talking to them and saying how, and some of them will be like, okay, I think I'm ready to stop it and see how it goes. Like, okay, so usually, but I would not try starting it after 60. If it's continuing, that's fine, but not usually starting it after 60, because then the risk factors do increase in terms of blood clots and strokes.
So thank you for that, Dr. Kathari. So Dr. Gorman, and this is where I have asked for your expertise in the past, because I think this is a common question. A lot of women are hesitant to talk about it, but it's a common question behind closed doors about just decreased libido, decreased sexual desire, recognizing it's an important part of relationships. What can we do to help women, and what are some of the treatment options?
Sure. So libido desire is so multifactorial. So it's, and every woman is different, but it is a common, finding that, when women get into menopause, often their libido does go down. And I think there, is likely for a lot of women a correlation with the changes in their hormones. But it's hard to have a really good libido if sex is painful. It's hard to have a high libido if you're constantly exhausted because you have so many hot flashes and night sweats, you're not getting any sleep. So it's really kind of looking at the whole picture. And, there is, mixed data, I will say, on using testosterone in menopause. And that's really something that individual women need to, come talk to their OB/GYN about, or be referred to somebody that is comfortable in using it, like Dr. Kathari or myself. And, it's not something that works for everybody. So I do bring it up because that is a question that I get often asked about, is just giving me testosterone in menopause going to really help my libido? And for some women, that may be the case. Some women, it absolutely has no effect whatsoever. And so we have to kind of really, look at libido and see what is going on. And there's a lot of times our sex life, our sexual health is going to change as we get older. But just because it changes doesn't mean it's going to be worse, or that it's not going to be pleasurable, enjoyable. And sometimes we have to kind of be open to how these changes are and open to trying new things and different things. And a lot of times it comes down to communication with our partners. And a lot of couples aren't in the habit of talking about sex and talking about how it feels. And that's very, very important to do that.
Thank you for that. And I know we're running short of time, but Dr. Kathari, one question that has come up several times, and I think it's really important, is the whole memory loss that's associated with changing hormones. Can you talk a little bit about that, and what are some techniques that people can use to help combat that?
So I tell people that when they come in, they're like, oh my God, my memory is going down. I said, it's a lot of biopsychosocial elements, right? Imagine someone is not sleeping properly, night sweats, you have kids, you have work. It's just people are multitasking so much. So I tell them, let's get it down to what is happening. How is your sleep hygiene? Are you sleeping okay at night? Are you having a lot of hot flashes at night? Night sweats, because that's going to affect your memory. If you've not slept, you're not going to be able to function properly. So targeting it to the particular symptoms. Then I tell them, I said, try, like we suggested, a sleep hygiene is really important. So, take magnesium at night, use the Be Calm app that we have for our members, relaxation techniques, and see if that helps. If that does not help, let's try some medications for your night sweats. Exercise is a big thing. Try exercising, not right before you go to sleep so you get all charged up, but but during the day. Diet has shown, like I said, a plant-based diet. So a combination of these things. And if that doesn't work, then we have, sleep studies to see if there's any sleep apnea that's going on, which is more into the primary care domain, but really trying to figure out what is honing down on what is exactly going on. So I think taking a multifactorial approach to sleep, and basically reassuring them that with so much of multitasking, some memory, all of us forget stuff. It happens all the time.
So thank you so much for that. And one of the things that I just want to quickly say, anyone who knows me knows that I live and breathe off of lists. So, for me, I have 4 kids, busy life, busy practice. And so I'm constantly putting things down on lists. I have a paper and pencil by my bed. So at nighttime when I'm having a hard time sleeping, I write everything down, and then I know it's off of my, worry list, and then I can go to bed. And so, keeping lists, I think, will help with memory loss and just keeping you on track. We are so appreciative of your time out of your busy clinical schedules, for your expertise. Thank you for your friendship. Thank you for, helping me through this and helping me with my patients. I know that people listening to this have been really impressed with the information that you have shared. We look forward to continuing this conversation. And for those of you that are listening, talk to your friends. This shouldn't be a well-kept secret, and we learn so much from each other and are there to support each other. Thank you very much, everyone, for your time.
Thank you.
Thank you so much.